In my review of veno-occlusive disease treatment and prevention in the European Society of Hematology 2020 meeting, I kind of put into context that veno-occlusive disease and sinusoidal obstructive syndrome are part of a spectrum of disorders that we now group in the endothelial damage syndromes, which include thrombotic microangiopathy, transplant-associated thrombotic microangiopathy, idiopathic pneumonia syndrome, fluid overload, capillary leak syndrome. We think that many of these very difficult to treat and very serious toxicities of transplant have a common triggering point, which is the damage of endothelial cells. Defibrotide is just one example of a drug that could potentially prevent the damage of the endothelial cells in pediatric patients. It has shown to reduce the risk of SOS and actually graft versus host disease. So I think drugs like defibrotide are now being further explored. We do know that complement activation plays an important role in endothelial damage syndromes. So drugs like eculizumab and narsoplimab are also being explored. And there are solely cellular therapies with mesenchymal stem cells derived from cord blood or from other sources that may also contribute to mitigating the toxicities of transplant. Why is this important? Because patients who have severe toxicities also are at higher risk of graft versus host disease, are at higher risk of infection, and probably have less of a chance of getting some form of maintenance therapy. We need to remind ourselves that relapse remains the most important cause of treatment failure. We have seen in the transplant space how lenalidomide maintenance can make significant impact in long-term disease control and overall survival for patients with myeloma. We see how brentuximab post-transplant for Hodgkin's disease has also made significant impact in progression-free survival. In the allogeneic setting, there had not been a yet successfully described strategy, with the exception of recent reports of FLT3 inhibitor, gilteritinib and sorafenib. Sorafenib, the randomized study was presented at ASH last year by the German group, suggesting a significant impact in progression-free survival and overall survival. So I think we're going to expect to hear more about these maintenance strategies. One which we're excited about is oral azacitidine. We participated in the phase 1/2 trial that was led by Dr. Marco Zalima and Case Western University. And this trial showed the tolerability and the safety of oral azacitidine. A recent randomized trial in the non-transplant setting showed that oral azacitidine improved progression-free survival and overall survival in non-transplant eligible patients. So we have reasons to suspect that this might also work in the setting of an allogeneic transplant. The MD Anderson group recently reported, Dr. Rambatul and the ASH last year, about the randomized trial of azacitidine subcutaneously. Unfortunately, this trial was not positive, possibly because of patient selection, but I do think that the oral azacitidine story needs to be asked.